My name is Nicolette Lam, and I'm going to talk about treatment of progressive multifocal leukoencephalopathy with pembrolizumab. Definition: We describe a patient with progressive multifocal leukoencephalopathy who had clinical stabilization and no progression as assessed on magnetic resonance imaging as a result of treatment with pembrolizumab, an immune checkpoint inhibitor. The patient had variable immunodeficiency complicated with diffuse large B-cell lymphoma, which was treated with chemotherapy and rituximab before the manifestations of PML.
Progressive multifocal leukoencephalopathy is due to an infection of oligodendrocytes by human polyomavirus (JC virus). It is characterized by widespread demyelinating lesions, mainly of the cerebral hemispheres, but sometimes of the brainstem and cerebellum. It usually develops in a patient with a neoplasm, mainly lymphoma and chronic myeloid leukemia, or immunodeficiency state. Most cases are observed in patients with HIV, but the disorder is increasingly occurring in patients who are being immunosuppressed for a variety of reasons, including some of the potent drugs for treatment of multiple sclerosis. Other important associations are with non-neoplastic granulomatosis, such as tuberculosis or sarcoidosis. The important clinical features are personality changes and intellectual impairment that may introduce the neurologic syndrome. Other manifestations are hemiparesis progressing to quadriparesis, visual field defects, cortical blindness, aphasia, ataxia, dysarthria, dementia, confusional states, and coma. MRI localized the usually non-enhancing demyelinating lesions without mass effect, but there is variability in size, location, and multiplicity. Diagnosis is more dependent on viral DNA isolation from CSF by PCR and on the context of immunosuppression. In this MRI, there is bilateral periventricular and subcortical white matter T2 hyperintensities. There is relative sparing of the cortex, no significant associated mass effect, no brain swelling. The only treatment available is restoration of the immune response by treating AIDS or reversing immunosuppression.
Applications in medicine. In November 2017, the patient began having difficulty with concentration and had aphasia, apraxia, amnesia, and gait ataxia. MRI revealed multiple lesions in the cerebral white matter that were hyperintense on T2 weighting sequencing. Polymerase chain reaction analysis of the cerebral spinal fluid detected 1,150 DNA copies of GC virus per milliliter. The total T-cell count at that time was 103 per cubic millimeter, and the CD4 count was 46 per cubic millimeter.
Welcome to USMLEFasttrack.com. The section we're going to talk about today is from First Aid for the USMLE Step 1, 2013 edition.
Page 445. Name a few non-common demyelinating and dysmyelinating diseases. Other demyelinating and dysmyelinating diseases includes progressive multifocal leukoencephalopathy, also known as PML, acute disseminated post-infectious encephalomyelitis, metachromatic leukodystrophy, Charcot-Marie Tooth disease, and Graves' disease. What is progressive multifocal leukoencephalopathy? PML is when there is demyelination of the CNS due to destruction of oligodendrocytes. What is PML associated with? PML is associated with JC virus or the John Cunningham virus, which is a type of human polyomavirus. What group of patient is PML most commonly seen with? PML most commonly is seen in 2 to 4% of AIDS patients in which they have reactivation of the latent viral infection. Describe the disease course of progressive multifocal leukoencephalopathy. PML is rapidly progressive and is usually fatal.
For more information on this topic, click on the link in the description section below. For a full USMLE Step 1 review, be sure to check us out at usmlefasttrack.com, where we help you review the entire first aid for the USMLE Step 1 with high quality videos and hundreds of detailed pictures for a better understanding of the material. So to learn from the best USMLE review book, be sure to check us out at usmlefasttrack.com.
Pros and cons. The poor prognosis of patients with PML when the disease is associated with an underlying hematological cancer has been shown in the case series. Mortality rates have been 74 to 100% with a median survival of 0.9 to 8 months. The rationale for the treatment of PML with pembrolizumab is based on the potential beneficial effects of increasing the levels of JVC-specific CD8 cytotoxic T lymphocytes.
The excitement these days is about immunotherapy, in particular a drug called pembrolizumab, which is a PD-1 inhibitor. This drug blocks the checkpoint immune signal, and so T cells have something called a PD-1 receptor. When bind to its proper ligand, PD-L1, can cause a downregulation of the immune system. And by downregulating the immune system is less able to find tumors and cause an anti-tumor effect. So when you block the checkpoint immune receptor, it can cause a ramping up of the immune system. And by doing that, it can cause symptoms that look like autoimmune disease. And so the four main organs that this drug, pembrolizumab, can target include the skin, the colon, the lung, and the endocrine glands. So it can cause something called a colitis, and the itis just means inflammation of the organ that it is preceded by. Colitis is characterized by diarrhea or bloody diarrhea. Pneumonitis, which is inflammation of the lung, can cause shortness of breath. Dermatitis, which is inflammation of the skin, can cause a rash. And then inflammation of the endocrine glands, such as the thyroid gland, can cause hypothyroidism or hyperthyroidism. And so if any of these happen, you should have a conversation with your oncologist about possibly holding the drugs depending on how severe the side effects are, and possibly giving steroids in the form of methylprednisolone or prednisone to help dampen the immune system and improve the symptoms that you're having.
Issue applied in Ecuador. In February 2018, the patient's symptoms worsened, culminating in mutism. The JC viral load in the CSF had increased to 1,019 copies per millimeter, and the lesion load as assessed on T2 weighted MRI increased with the development of large lesions in the frontal lobes. After 5 infusions of pembrolizumab administered at a dose of 2 milligrams per kilogram of body weight, approximately every other week over a period of 10 weeks, the patient's mutism abated and he began speaking. In addition, the size and number of lesions on MRI decreased and JVC was no longer detectable in CSF. Conclusion. The patient has remained stable at the end of March 2018 with persistent but abating psychomotor, slowing aphasia, and disorientation. The JC viral load in CSF has remained undetectable apart from one determination of 500 copies per millimeter that correspond temporally to the extension of infusion interval to 4 weeks for several days after the 8th infusion, but no other adverse events. There was imaging evidence of the immune reconstitution inflammatory syndrome over a period of 4 weeks on 2 MRIs, but the patient did not have clinical symptoms. This case report supports the concept that blocking the pathways of programmed death one or of its ligands can ameliorate JVC infection. Thank you.